Well, it is my distinct pleasure and honor to introduce our next speaker, Dr. Marie McCormick, the person of the hour and of the day. We've heard a lot about Dr. McCormick this afternoon, about her pedigree academically, her accomplishments, her so much about her career and contributions to maternal-child health. And so I won't rehash those. What I'd like to do instead as a means of introduction is just to speak very briefly about Marie as a mentor. In preparation for this day, Dr. Pursley actually asked all of us in the faculty if we would be so kind as to email him some thoughts about Marie as a mentor, and perhaps if we could sort of think about one word to describe her mentorship, what would that be? And it's taken me some time to think about it, and it wasn't that I was just busy on service, Dwayne. I wasn't ignoring your email. But I wanted to be reflective and thoughtful, and I have to say the word I would use would be humility. And three things kind of come to mind that I'll share with you again briefly, because I know we'd all like to hear from her. The first has to do with humility as a mentor. At the BI, we actually have a group of young health services researchers who come together every month or every other week or so to talk about works in progress. We call it neonatal work in progress, or NEO-WIP. And you know, it's those of us who are in early stages of development, from trainees to early career people and beyond, some more established people, who come and talk about their work and to get feedback. And Marie is there every time, right? As a full person, think about it, a full professor coming to listen to a research assistant, a pre-doctoral, person, to a postdoctoral fellow, to an early career investigator with multiple degrees, to come and listen thoughtfully, seriously, and to give feedback on those research ideas. I mean, to me, that's humility, right? She's not above coming to engage with us around the table. The second has to do with humility in the face of evidence, and particularly with knowing what we know, having a long view. I don't think I'll ever meet anybody who has such a deep understanding of the history of maternal-child health. She always, when I talk to her about something, she always has a story, a recollection, something about when that happened, where that came from. But also knowing what we don't know and being honest about it, being humble in the face of, not being afraid to say, I don't know, maybe we should think about that, maybe we should investigate. And the third, perhaps most importantly, is to be humble in the face of always remembering for whom we do this research, for whom we do this work, both in research and in practice as a pediatrician. We do it on behalf of children and their mothers and their families. And to me, that's the most humbling of all, right? It's not about us, it's not about the leader, it's not about the mentor. It's about those people for whom we're working. And so, Marie, I thank you for instilling me with those values as I move forward. I personally could go on and on about how my career would not be what it is right now without your encouragement over these past 10 years. So I thank you, and on behalf of all of us, I would like to welcome you to give us some thoughts.
Well, you've heard about all these wonderful things, and you've seen all these lists of activities and so forth. And so I'm going to start a little bit about how I got started. And I tell my students, just like no research is ever the way it's described in the paper, no career is ever the way it's described in the CV. Okay, there are a lot of ins and outs. And so when I first applied to medical school, I said I wanted to do research to prevent cerebral palsy and mental retardation, now intellectual disability. This goal was in response to the children that I had cared for as a nurse's aide in a local hospital, and their condition made a very strong impression on me. In other words, I didn't want to see it again. My first experience in the wet lab, while interesting, convinced me that was not where I wanted to be. Through a variety of circumstances, I was introduced to health services research, and I think Peter has made a case that the overlap between MCH and health services research is very large. I will tell you that one of the considerations was that they were giving the biggest summer student stipends from that department. It was not a well-established area of inquiry in medicine. There were only, after all, 2 to 3 academic departments in the country, but I liked the breadth and methods of research and found that I had some talent for it, and in particular, I was drawn to program evaluation. I would have to say that that research focus was not a particularly respected one. As my medical school roommate said, she didn't know what I was doing. I will say 10 years later, she said she wished she'd done it. But I enjoyed it. And as I tell my students, you really have to like research because it's not an easy way to make a living. There are really, as far as I'm concerned, only really 3 clean moments of reward in research. The first we've heard a little bit about, which is the identification of an important problem, but more importantly, you can see how to solve it, that it's actually feasible for you to do the research. The second is when the first data come in, and for me it was answers to my questionnaires and surveys. I will have to say often those responses were quite unanticipated and actually reinforced the complexity of the human experience. And finally, when you see your first results, I used to say your printouts, but of course that's outdated. And then you know a bit more than the rest of the world, and you are contributing to the world's sum of knowledge. The rest, quite frankly, can be a slog through grant applications, pilot studies, IRBs, and responding to the journal editors. So I was fortunate that I found an area of research that I enjoyed. I was also fortunate in having mentors along the way and colleagues, which have been described, who collaborated with me, and finding the resources to do the work that I wanted to do. By chance, as was mentioned a couple of times, the first program evaluation I worked on was examining the effect of a national demonstration program of perinatal regionalization. A major question was whether if you increased the survival of high-risk neonates, were you also increasing morbidity? The answer was no. But it had focused me because, in fact, at the time I was sitting on the largest data set on low birth weight infants, some 10,000 of them. As Dwayne has described, my work has continued to focus on the outcomes of pregnancy, and in particular, understanding the outcomes of very premature infants and ways to improve their outcomes. It seems a somewhat circular route, but I did, in fact, fulfill my medical school application goals, because the significant problems in premature infants include cerebral palsy and intellectual disability. From very early on, I also knew I wanted to be in academia. While I was not interested in a fast-track career, I also did not plan to be an assistant professor for life. However, today's event and the kind of outpouring that has occurred was never even on my bucket list. I'm incredibly honored by those of you who came here, both speakers and attendees, and frankly, I'm a bit overwhelmed. I keep wanting to look over my shoulder to find out who these people are really talking about. After all, I was just doing what I enjoyed. So the first lessons learned personally included finding an activity or field that provides you gratification regardless of its prestige. The prestige may change. While days like today are wonderful, you may need a greater ability of delayed gratification than I had if that's your goal. The second is a little more less high-powered. Be careful in what you write in your grad school application. But we are not here just for me. We're here for MCH. Back in those days, if you had asked me about the need for MCH, especially in schools of public health, I probably would have been neutral to somewhat negative. I was a pediatrician, after all, and naively assumed that everyone understood the primacy of children and their families. I also thought everyone understood the value of immunizations, but that's another story about naivete. But experience has proven that assumption incorrect. I will give but one example. Until the most recent edition, Maxie Rosenau, the so-called textbook of public health, had no chapter on MCH, despite having whole chapters on the epidemiology of various cancers. I would like to think the current chapter, no matter how brief, and it is brief, was the result of my badgering the current editor, Bob Wallace, about the gap. Why this apparent neglect? In considering the gap in research on issues of children versus those of adults and even older adults in the United States, my colleagues refer to demography, disease, and development. The first, demography, refers to the proportion of the population that MCH deals with. For example, there are 4 million births a year in this country and roughly 80 million women of childbearing age range. Thus, at any given year, only 5% of women are pregnant. Children and youth represent less than a third of the U.S. population. So MCH deals with a relatively small fraction of the health problems that are seen in the United States. And this is complicated further by disease, which has meant the prevalence and distribution of health problems in the MCH population. Of the 4 million births we've seen, up to 10% may be born prematurely, but only 1% of those births really require the full-blown neonatal intensive care that Dwayne and his colleagues provide. About 2% will be born with major malformations, and by the way, they overlap. Congenital heart disease is the largest contributor, but the rest are comprised of a large number of increasingly rare and unfamiliar conditions. I suspect you're all familiar with maple syrup urine disease and the gangliosidosis. Among children, less than 10% will be hospitalized in any year, and 15% will be classified as having special health care need, which is the new terminology and expanded terminology for chronic illness. Although of significance, there are only 700 maternal deaths a year. The good news that these figures suggest is that most children are healthy and most pregnancies go well. However, the low fraction in the MCH population, combined with a multitude of infrequent health problems, makes it difficult to conduct studies about both the conditions themselves and the groups most vulnerable to these health issues. And finally, development indicates that the issues affecting families and their children are a moving target. We've heard about the early adverse health events and environmental experiences may be expressed in a variety of outcomes much farther downstream. For example, we've already heard some discussion about the variations in fetal and infant growth, may be risk factors for adult onset cardiovascular disease and metabolic disease far in the future. Further, changes in environment, including the policy and economic environment, may alter these trajectories both for good and for evil. In other words, the arc of the effects of childhood experiences is long. Good experiences may have great payoff, and adverse experiences may lead to a cascade of future problems. Hence the focus in maternal and child health on prevention. There's a little hooker about this prevention thing. It is largely health and education who invest in the prevention. It is welfare and the prison system that reap the rewards. So you don't get a lot of reward for doing this kind of stuff. Finally, funding for understanding and altering childhood experience is limited and spread over a range of federal, state, and local administrations, as we've already heard. The Maternal and Child Health Bureau has been a steady supporter of both education and research in MCH, but it represents exactly 0.6% of social welfare funding on child health. Peter has talked about the dollars going to the National Institutes of Child Health. That represents 11% of NIH funding. Concerns about child health are spread over welfare, the Departments of Agriculture and Education, and Financing Administration. Tracking the use of these services and understanding their effects across these sectors is not simple, either for researchers, and God knows, not for the families. I will also have to say that MCHB may have contributed a bit to some of the diminished stature of MCH in schools of public health. While the training grants like ours, now in its 63rd year, have been critical to sustaining the education of MCH professionals, the constraints imposed by these training grants in the past created problems for departments of MCH in fitting into and belonging to a changing academic atmosphere. The training grants were initiated in the post-World War II era and informed, I think, by my predecessor, Dr. Martha May Elliott. She had had major responsibilities at the Bureau for direct delivery service during the Depression and war. And thus, the focus of the grants was in replenishing the MCH public health workforce, largely for Title V agencies, okay, not for every child health service. And she did this by insisting that there would be resources for professionals to get an MPH degree and providing technical assistance and continuing education to those in the field. I will simply say that the structure of the training grants did not change for over 20 years. This is a period in which schools of public health underwent major changes, from being largely focused on master's degrees to expanding the degree programs to doctorates and their inherent need for research. In addition, the funding for the major schools of public health became much more dependent on the research being brought in by the faculty. When I took over the grant in the early 90s, I was still required to have a physician, a nurse, a social worker, and a nutritionist on my faculty, not for educational reasons, but because that was the staffing of an MCH public health clinic. Such clinics had long vanished from the Massachusetts scene, with their responsibilities assumed by more full-service entities like neighborhood health centers. The narrow focus on Title V agencies not only limited awareness of the expansion of services in these other entities, particularly in the Northeast, where we've not had a terrifically strong county health government, county government providing services, but also they sort of missed some of the professionals who were emerging, who were coming out of the hospitals, doing research and service in the community, and these were, in part, the health services researchers that we've talked about. When deans looked at these departments, they saw our faculty engaged in a variety of activities in the community, but not generating much new knowledge. I will also have to say that the dollars per year had not changed very much, so that increasingly the training grants were paying less for the MCH activities, but the programs were not contributing to the bottom line. Moreover, there was no money for doctoral students, even to replenish MCH faculty. And it also meant that developing the evidence base for MCH interventions lagged, as this was not seen as part of the mission. Much has changed since then, particularly under the leadership of Dr. Liu and his colleague, Laura Kavanaugh, ably supported by our project officer, Michelle Tissue, of whom I can only speak of the highest terms. They have been fabulous. The primary commitment of the grantees to professional education at both the master's and the doctoral levels, and the importance of generating new knowledge to move MCH forward, have been recognized in our new titles, Centers of Excellence. While support of Title V agencies is still a priority, the training programs are now actively engaged in collaboration to develop rigorous academic experiences that will both enhance the education of our students and provide the kind of assistance that the programs need. And Wanda described this in terms of this evaluation practicum, but this was really an attempt not only to provide services to the Title V agencies, but also to make sure that the students were getting a rigorous academic introduction to this. The program begins with a week course that is an intensive didactic instruction and program evaluation, and then the students go out to the field, to the states, and design a program evaluation for the state. And as Wanda indicated, it was supported by the Division of Reproductive Health and CDC. Other programs are also developing innovative strategies. One of these is a pipeline project to try to engage more underrepresented minorities in maternal and child health. And we're also beginning to link these programs, so that last year our students developed a program evaluation, and in the summer the pipeline students finished the evaluation. And in addition, MCHB is also fostering the development of MCH programs in schools of public health. Thus, I think we are entering an era with a reinvigorated cadre of academicians and professionals that will contribute to new and exciting programs addressing the needs of children and families. The alignment of concerns and goals with the Bureau and the training program bodes well for the coming years in once again asserting the importance of issues and identifying interventions in order to shift the trajectories of vulnerable families towards healthier futures. I would simply indicate that besides this room, one measure of the new vigor is the large number of students in our MCH concentration, which averages 40 to 50 per year. Again, I would like to thank all who contributed to this day. It has been a wonderful celebration, and I hope we all go forward and do good things for kids.